I would first like to acknowledge and thank my co-authors at Rady Children's Hospital, the Orthopedic Biomechanical Research Center, and UCSD for their work and collaboration on this project. As an introduction, developmental dysplasia of the hip is a common pediatric disorder with an overall incidence around 5 per 1,000 hips, with 80% affecting females. The dysplasia results in instability and abnormalities in gait and function. The aim of treatment for developmental dysplasia of the hip is concentric reduction of the hip. Early intervention focuses on the immobilization of the hip in a flexed and abducted position using a cast or harness. Children with residual dysplasia are often treated by surgical intervention, such as a pelvic osteotomy. Comparative analysis of different osteotomies is usually limited due to large variations in dysplasia and the fact that each patient only gets one osteotomy. However, 3D printing technologies enable the use of patient-specific anatomic models in mock surgery for comparative analysis of different osteotomies. The purpose of the current study is to evaluate the differences in acetabular coverage angles and volume resultant from Pemberton, Dega, San Diego, and Salter osteotomies using 3D printed technology. Included in the study are patients aged 3 to 7 with a diagnosis of acetabular dysplasia and a preoperative pelvic CT scan from 2007 to 2015 from a single institution. From these patient CT scans, bone and cartilage tissues were independently segmented and then rendered into a 3D printable format. 4 identical mock pelvises from each patient were printed using a dual material printer, shown at right, which allowed for simultaneous extrusion of a rigid material to simulate bone and a flexible material to simulate the cartilage. Specifically, we utilized a rigid acrylonitrile butadiene styrene, or ABS, to simulate bone. That's the blue material, and a flexible, semi-rigid thermoplastic polyurethane, or TPU, material to simulate the triradiate cartilage and pubic symphysis. That's the tan material. The combination of the rigid and flexible composites may closely mimic the cartilaginous and osseous mechanical and structural properties of the developing hip. As seen in the middle image here, ABS was chosen because it is easily imaged and discerned by CT, allowing for quantitative image analysis. Additionally, ABS has been shown to simulate the cutting properties of bone using a surgical oscillating saw. As shown here, each print underwent a pre-surgery CT scan and 3D rendering for analysis. Subsequently, mock Pemberton, Dega, San Diego, and Salter osteotomies were performed on the quadruplicate set of 3D prints for each patient by a fellowship-trained pediatric orthopedic surgeon. The first 3 osteotomies are considered incomplete or reshaping osteotomies because they function by using an incomplete bone cut and then bending the pelvis to change the shape. The Salter osteotomy is considered a redirectional or complete osteotomy because the bone is completely cut and then redirected. The conventional belief is that the redirectional osteotomies are volume neutral, whereas the incomplete osteotomies are not volume neutral, and in fact reduce the volume. Post-mock surgery CT scans were also acquired for each 3D print, which were then rendered in 3D. Acetabular volume and octant coverage angles were measured and quantified from these 3D renderings using a custom MATLAB script. Acetabular surface from these 3D renderings were automatically identified, and a best fit sphere utilizing least squares regression and the articular surface boundaries on each hip were identified. These were used to approximate the acetabulum center of rotation. Acetabular direction vectors, shown with the green arrows in the images, were calculated by determining the surface normal vectors at each point of the acetabulum and integrating these surface normal vectors over the entire surface of each acetabulum. The volume was calculated by the hemisphere of the best fit sphere. The coverage angle is the angle between the line connecting the center of the best fit spheres for each pelvis and the edge of the acetabulum. This is shown in image A, where the green dots represent the center of the best fit spheres. The coverage angle for the octant section calculated using the MATLAB script is the average of the coverage angles within the specified 45 degrees or octant of the acetabulum edge. In image B, there is a representation of the 5 clinically pertinent coverage angle octants of the acetabulum: the superior anterior, the anterior, the posterior, and the superior posterior octants. For statistical analysis, pre- to postoperative changes were compared using repeated measures ANOVA with Bonferroni post-hoc test for normally distributed data, and the Friedman test and the Wilcoxon signed ranks test for non-normal data. The mean pre- to postoperative difference between different surgeries were compared using ANOVA with the Bonferroni post-hoc test for normally distributed data and the Kruskal-Wallace and Mann-Whitney tests for non-normal data. Significance was set at p-values under 0.05. 14 hips and 14 patients were included with a mean age of 5.4 years. 13 of the patients were female and 1 was male. Looking at changes in acetabular volume due to the different procedures, we found that mean acetabular volume decreased significantly from preoperative mean volumes in all cases. The Salter osteotomy resulted in the smallest change in volume. However, it still resulted in a significant decrease in volume. When comparing the mean change in volume between procedures, we found the mean volume change for the Salter osteotomy was significantly less than each of the other osteotomies. In addition, the mean change in volume for the Pemberton, Dega, and San Diego osteotomies were not significantly different from each other. Looking at the change in coverage angles resulting from the different procedures, we found that when compared to preoperative mean coverage angles, the postoperative mean coverage angles were different across several regions. We found that the San Diego osteotomy resulted in greater coverage in the posterior, superior posterior, and superior regions. The Salter osteotomy resulted in greater coverage in the superior region, and the Pemberton and Dega osteotomies resulted in greater coverage in the superior, superior anterior, and anterior regions. In conclusion, we found that acetabular volume decreases found in the study support the conventional belief that redirectional osteotomies such as the Salter are more volume neutral than incomplete osteotomies such as the Pemberton, Dega, and San Diego. However, this study shows that even the Salter decreases acetabular volume. Additionally, the study demonstrated that each osteotomy used for correction of acetabular dysplasia uniquely changes acetabular coverage in different regions. Importantly, these differences in volume changes in acetabular coverage between osteotomies should influence surgical planning to optimize patient-specific defects. Here's a reference for the technique of the octant angle measurements. Thank you for your time listening.